Okay, thank you all. We're going to try and go through these new E&M codes that are going to go in effect here January 1 for the CPT changes that the AMA has made. The best advice I can give you is to tell you to kind of forget everything you do right now as far as documentation and that goes, and try and get acquainted with these new tables and new ways that the CPT codes for the evaluation and management will be determined. So I just want to make sure, understand this. These are examples. They're not a substitute for your judgment, especially for each individual patient. This is only for the new guidelines until the end of the year. You still use the current guidelines, and they're effective January 1, 2021. The American Medical Association is the one that has the copyright and the registered trademark for CPT. And Dr. Holloman here, who was in charge of this committee or worked on this committee, basically summed this up as saying the whole point was to have people not document stuff that was not necessary, not relevant to the clinical management of the patient. So most everything you see tonight comes straight from the AMA. Again, CPT is a registered trademark of the AMA, so I wanted to quantify that because we'll be referencing that all night. If you're looking for some references, some real good references, the E&M compendium from AMA is an excellent resource. You can get that on Amazon or through the AMA, and these wall charts are good too. For pediatricians, the AAP has put out a good book, and again, that's available on their website. We've combined tonight's meeting to kind of give examples of both adults and peds, so we've kind of used some generic examples. So how are we coding right now? Well, the last updates were almost 25 years ago in 95, 97. Documentation requirements are excessive and many times non-contributory to the chief complaint. We can code using time, but very outdated rules. Currently we must be face-to-face, and over 50% of it has to be counseling and coordination of care. So what's going to change? Well, just the E&M codes, the 99201s through 215s. Although we're going to delete the 99201, there are no changes to any inpatient or observation codes. The changes are to the medical decision-making table, which are critical because that's where most of your codes are going to come from. And they've changed the way time also works, and we'll go over that. Coding based on time is not necessarily a volume of your documentation. So all that stuff that you've been cut and paste and putting in there for the somebody to audit your chart, that's no longer needed. And there's going to be some significant changes to the extended billing codes. So big thing is there's no longer a required specific level of history and exam. History and exam only need be relevant to the reason for the visit. So in the past, we felt kind of forced to kind of document stuff that wasn't pertinent just to support the E&M level we put in there. You don't have to do that anymore. So the key elements of these changes, again, we're eliminating that history and physical as elements for code selection, but they're still significant. We still have to document some things, but they're not alone. You don't use them alone to determine the visit's code. We're allowing physicians to choose whether they want to make the decision on E&M from an MDM or medical decision-making or total time. So they're giving you a choice. What this does is better recognizes the work that you do non-face-to-face, like care coordination. And they also want to change the medical decision-making criteria to move away from simply adding up tasks. Now they focus on the tasks that affect the management of the patient's condition. All this stuff, this cut and paste, this is, like a history and physical, that's out the door. You document what you think is medically appropriate. This is the new CPT code description, a medically appropriate history and exam. This is the old one that's still in effect right now, detailed history, detailed exam, medical decision-making. And you can see the time has changed, and we'll go through that here at the end. This point system that they use to audit charts, that's gone too. So this is what we're going to be left with. We're going to be left with medical decision-making or time to determine our E&M visits codes. The most important one for you all is going to be the medical decision-making. That's where the majority of your things are, your codes are going to come from. So first, is Medicare following these new guidelines? Well, just last night on the 1st of December, they announced that they are largely following these guidelines. So yes. Are commercial payers following these guidelines? Your payer contracts sometimes require a different way to calculate E&M codes. Most of them require CPT codes. So the best thing you can do there is check with your payer. Blue Cross Blue Shield of North Carolina, it's very clear what they have in their book right now that if you're using CPT, then yes, you can use these new codes and they will honor these new codes. I think everybody knows the difference between a new and established patient, but just to make sure, if less than 3 years, it's an established. New patient is over 3 years, so the new would be the 99202s through 5s, and the established would be the 212s through the 215s. So what is a problem? Well, anything's a problem that the patient comes in for that's a disease, condition, illness, injury, sign, symptom, question, complaint, finding, or some other matter. The critical thing to remember is you don't have to make the diagnosis at the encounter. You just have to include it as part of your decision, whether you're ruling it out or whatever. So a problem addressed is an issue evaluated and treated at the encounter. Only problems addressed are counted in the MDM. Now, if you consider further testing that's not elected because of risk versus benefit to the patient, you can also include that. So sometimes you can't do a test because of a high deductible or give a medicine or insurance authorization won't allow it or the patient defers for some reason. But if you're considering it, you document it. And if it's a higher level, that gets you credit for that medical decision making. Problems listed if you're just RAFing, yearly you have to put every diagnosis code in. If it's not related to the reason that they're at that visit, then it doesn't count towards the MDM. You can still put it in, it just doesn't count. If a patient's being managed by another provider, a specialist, and you put stable, managed by cardiologist, no change in treatment, you can't, that's not a problem addressed. Same if you just refer to dermatology for a full skin check, you don't qualify as a problem as being addressed. And just simply listing problems in the medical record, those again, are not addressed problems. So this will be the chart we'll build from. Again, history and exams out the window. All you have to document which is appropriate. In some cases, you may not even have to document a physical, but we'll go through what we think you should document. Again, we've got the 4 levels of medical decision making. They've stayed the same. The times have changed. The numbers you want to remember for 2021 are 15, 30, 45, and 60 for the new patients, and then pretty easy for the established patients, 10, 20, 30, 40. So let's focus on the MDM, the medical decision making. None of these levels have really changed. We've got the 4 levels, the straightforward, which are the 202, 212s, where there's minimal management, minimal amount of data, minimal risk of complications. And we go up then to the 203s and 213s, which are the low complexity, where we have limited options, limited amount of data, and limited mortality and morbidity. And then, of course, advancing to the moderate, which are the 204s, 214s, where we have more options, a moderate amount of data, and there's moderate risk. And then, of course, we have the highest ones, the 99205s and 215s, where you have an extensive amount of data to review and a high risk of complications of morbidity and mortality. Medical decision-making, 3 elements. You've got to remember, those 3 elements are what's going to make up your MDM decision-making. First element is the number of problems and complexity. The second one is the amount of data you've reviewed and analyzed. And then the third is the risk to the patient. You put those 3 together, you satisfy 2 of these 3 elements, and that's going to give you your code, either straightforward, low, moderate, or high for the appropriate E&M code. This is the chart you probably want to keep close to you. You want to memorize it. You want to put it in your phone. You want to put it in your exam room, because we're going to build this chart 1 row at a time, but each one of these are our 3 elements. And remember, we need 2 of the 3 elements in any one of these categories to satisfy that level of complexity. 2 in the low would give you a low. 2 in the moderate would give you a moderate. So let's focus on first the number of diseases and problems. Again, this chart, we're going to build this column right here. 2 of 3 are needed. Just because you satisfy it in this one, in the number and complexity, doesn't mean you've satisfied that level of MDM. You have to satisfy it in a second category. So these are the different ways that the AMA has defined the complexity and problems. We're going to go through them one by one. You know, a straightforward is a pretty limited thing. A low is probably a stable. This is probably going to be the one you're going to use the most, like strep and things like that, acute uncomplicated illnesses. Moderate, these are your chronic illnesses with exacerbation or systemic symptoms. Again, we'll go through examples of each one of these. Just to refresh, in 99211, it does not have a minimum time. It is not specific for MDM. It's just something where services performed and physician presence not required. So if you schedule a follow-up for a weight check, a blood pressure that you have scheduled as a provider, not if prompted by the patient, suture removal, asthma, or diabetic counsel is not repetitive. You can't keep doing it over and over again, or a dressing change. These things would be your 99211. So those are not part of this chart for the problems for complexity. Straightforward is our basic level, 99202 or 212. It runs a definite prescribed course. It's transient in nature, and it's not likely to permanently alter our health status. So these are the simple things: colds, tinea, uncomplicated insect bite, type of rash. The next category, of course, is the low, the 203 and the 213. Each one of these upcoming categories is going to have more and more ways they describe the problems that you will include. So 2 self-limited or minor problems. So if you have 2 of these things that are pretty straightforward, the tinea or bite, cold, things like that, that would qualify you now from a straightforward to a low. Stable chronic illness, the patient is at a treatment goal. It's very important to understand what that means. First of all, chronic illness is going to be longer than a year, and there's some risk of morbidity and mortality. But a patient is not stable even if their condition is not changed and there's no short-term threat to life or functions. So basically, this would be your well-controlled ADHD, your controlled asthma, and your controlled blood pressure, controlled diabetes that are at their goal. If their goal's less than 130, less than 85, and their blood pressure is 120 over 80, then they're at goal. If it's 140 over 90, they're not a stable chronic illness. An acute, uncomplicated illness or injury. Of course, this is pretty straightforward too. Cystitis, allergic rhinitis, otitis, pharyngitis, ankle sprain. These are just new short-term problems, probably the most common thing we're going to see for acute things. Low risk of morbidity, if treatment is considered, pretty much low risk of mortality, full recovery. If one of these self-limited problems doesn't fix itself, then that could be considered a acute, uncomplicated illness or injury. Now, moderate probably has the most categories here. There's actually 5 categories of problems. The undiagnosed illness with an uncertain prognosis. Well, a good example of that is a new breast lump or a new breast mass or a new neck mass. Acute illness, systemic symptoms. Now, systemic symptoms like COVID, colitis, pyelo, pneumonia, spontaneous bruising. It causes systemic symptoms with a high risk of morbidity. So again, these are still all under the moderate, your 99204, 214s. And then last one, we had an uncomplicated injury, and this one we had a complicated injury for moderate. Requires evaluations of the body system that are not part of the injured organ, or there's extensive injury or multiple treatment options. A head injury with loss of consciousness and lethargy. That's a real good example of this one. The other 2 categories under our moderate is 2 or more stable chronic illnesses. Again, one of the most common things that you're probably going to do is diabetes, hypertension, asthma, ADHD. So patients come in with these stable diabetes, hypertension, has 2 of them, 2 or more. So you could have 6 of them, you're still going to get crowded for more. So it's 2 or more. Chronic illness with mild exacerbation or side effects. So these are going to be things like mild moderate exacerbation of asthma, social anxiety, you're not able to leave the house, ADHD with tics, uncontrolled diabetes. It's acutely worsening or poorly controlled. It requires additional care, requires additional treatment for the side effects. Critical to this one is there's no consideration for hospital care. Hospital care is going to be part of our high, and there's really only 2 categories here for our 99205s and 215s. It's a chronic illness with severe exacerbation, progression, or side effects of treatment. Well, of course, that would be something like COPD, asthma, or CHF, where you have to consider putting them in the hospital. And then there's the acute or chronic illness that's posing threat to life or bodily function. Again, pretty serious things. Renal failure with acidosis, abrupt change in neurostatus, depression with suicidal ideations, diabetic ketoacidosis, COVID with shortness of breath, and multiple GI symptoms. So just to reemphasize these problems is, again, these examples for the low, we've got the self-limited, which are 2 or more, the diaper rash, the simple cold. We've got the stable chronic, all the well-controlled things, hypertension, diabetes, COPD, asthma, and then your acute uncomplicated illness or injury, which pretty much your catch-all for most of the things you see: cystitis, allergic rhinitis, otitis media, pharyngitis, ankle sprain. The moderate, again, we got 5 different categories here, 6 different categories. The one undiagnosed problem, the neck mass or the breast lump, the acute complicated injury where you've injured a head. Now you've got to look at other body parts, the loss of consciousness and lethargy because of the symptoms. The chronic illness with side effects, so ADHD with the tics, an ACE-induced cough, a statin with joint pain. All of these are moderate. So they check that box, that first column, if you've got that. Acute illness with systemic symptoms, of course, colitis, COVID, pyelo, pneumonia. And then again, we talked about the 2 or more stable chronic. If you set, this is patient-specific goals. It's not necessarily goals set by any academy or something. If you think the patient needs to be below 130 and 85 and they're not, then they're not stable. If you think their diabetes needs to be below 7 or 7.5 and they're not stable. And then our mild exacerbations that we've talked about. And then, of course, the high, I think, are pretty straightforward. You know, your side effects, Stephen Johnson, heart block from DID, serotonin, that would be a good example of that. These are going to be your 205s, your 99215s. Again, the chronic illness posing threat to life and the chronic illness with severe exacerbation. I think those are pretty straightforward. So let's look at some other issues that come up with the data and are complex complexity here with the problems. Symptoms can cluster around a specific diagnosis, but each symptom is not necessarily a unique condition. So let's look at that. Low-grade fever, body aches, postnasal drift with cough and shortness breath. Well, you've got 4 different symptoms here, each of which could be mild or together could make something more serious. Again, this could be an acute, uncomplicated, low medical decision-making URI if you don't reference that you considered these other issues could cause something more systemic. If you do document, hey, these things could mean that something more serious is going on, like a pneumonia, then now you have made this an acute with systemic, which is the modern ADM. So you don't have to make the diagnosis. You just have to document you were thinking about it and consider it, and it's reasonable from the patient's complaints. You may have a wide differential. You could look at a ton of different things and then come up with something that's benign, like just an upper respiratory condition. It doesn't matter. If you have to consider those things because the patient's complaints go with that. And a good example here is COVID versus bronchitis. If you just document bronchitis, but you really had to think about, hey, this patient in today's time could actually have COVID, your MDM would be low because it's an acute, uncomplicated illness. But if you document, hey, this is bronchitis, but we had to consider COVID. We actually had to send out a PCR test, or the patient had body aches, cough, headache, fatigue. So again, it's all in what you document. If you think it, you've got to document it. Another issue with number and complexity is multiple problems create higher risk. So a patient with chronic kidney disease, CHF, AFib, chronic peripheral edema, and versus a patient that doesn't have a significant medical history, change the MDM. If they came in with an ankle sprain, you're probably going to give an NSAID and do some other things, but you've got a patient with kidney disease, that's going to be a bit different. And your ankle sprain with the patient with no significant medical history, it's going to be low, acute, uncomplicated. But when you've got the patient with the heart failure and everything else, you've got to you've got to look at all these other body systems, because if you use the NSAID, it interacts with the blood thinners, you can worsen the edema, they're not getting around fluid retention. So again, if you just write ankle sprain and you don't write that you considered all these other things, you can only be a low. If you write you considered all these other things, you're a moderate. So the second element is data. This one's a bit more confusing, and this is where some of the gray areas have come, and some of the things are yet to be defined by the AMA. They've tried to get away from counting, but you're going to see there's some numbers here. You've got to meet one of 2 of these categories. There's 3 different categories in the moderate and high, and we'll go through this one by one here. So they came up with 3 categories for data. One is your typical stuff, your documents, your labs, your x-rays, your notes, your other testing, or independent historians, and we'll define that. Each unique test, so every test you order is counted to meet that threshold. If they need 2 or 3 activities and you review 2 different documents, or you order 2 different tests, that counts. Referring back to your own notes never counts. This independent interpretation of tests is more for specialists, but I'll tell you what that means. It may come into play in some of your offices. And then, of course, if you discuss or manage this with an external physician or another qualified healthcare professional or appropriate source, that's your 3rd level of data. So again, very simply, we already talked about the things that are kind of self-explanatory, the records, the tests, the other information. If you're getting some communication from specialists, that's all included. But the ordering, I want to go over this ordering. So if you order, it's each unique test. You order a CBC, BMP, echo, and x-ray. That's 4 different tests. But you don't get credit for ordering and reviewing the test. The order and review is credited at the time you order. Now, if you review a test that's not part of the encounter and drawn outside, then you do get credit for that. But here's an example. You order a blood test for an encounter on December 1st, and you're having the patient coming back December 8th. You don't get credit for that review on the 8th. You get credit for that review on the 1st. So what are some other things that are not included? And this is where we get a little bit of discrepancy. Any service that you do, that you report a separate CPT code on that same day with that E&M code, they're saying you can't include. And I'll show you where, for the most part, it makes sense, but I will show you where there's some gray areas there. So draining an abscess, joint injection, spirometry, Holter, x-ray, bone density, all these things you're doing, these things require reports. These, of course, are procedures that you're getting using a modifier 0.25. So it would make sense that you're not going to count them. You're getting paid for them separately. So again, you can't count them in your MDM. So if you bill for it with a CPT code, then it's not counted. The only question comes into when you bill these rapid tests, flu, strep, pregnancy, RSV, and mono. And we're going to go into that a little bit later, and I'll give you my take on that. There's a lot of controversy between people right now, and the AMA has not really defined it very well. But just again, to reiterate, CPT code equals 1 unique test. So for every CPT code, for every test you order that has a CPT code, that's a unique test. If it's a panel, it's only 1 test. Even though a CMP may have 6 or 7, or may have multiple chemistries in it, it's only one test. Same thing with liver lipid. If you order hemoglobin A1C, BNP, CBC, TSH, that's 4 tests, and that's going to be moderate complexity. Again, you're ordering any of these tests like asthma control testing, depression screening, advanced planning, joint injections, earwax, foreign body. All of those are going to have a separate CPT code. You're going to vote, you're going to use a modifier usually, and you're going to bill them separately. You don't get credit for that. So, and you never count time that your staff performs these tests. So let's go through these different categories here. Low, again, straightforward, there's not going to be any data. In the low, you've got to meet one of these 2 different categories. Category 1 says you've got to review at least 2 different notes or a combination of reviewing results of each unique test or ordering. So you can order a test and review a note, that's 2. You can review 2 notes. You can, any combination there qualifies that. And if you get category 1, you've automatically met data for low. And number 2 is an independent historian. So the independent historian is probably more pertinent for the pediatricians and others, because this can be a family member witness or other provides patient history when the patient can't provide a complete history. It's required, though, that the provider must judge that the history is needed. For the adults, a husband that doesn't want to talk or doesn't want to tell things and the wife has to chime in, that doesn't count. New info has to be, because that the husband's competent, he can do that. It just chooses not to. So new info required, well, that's when you have to make sure that the historian provides new information. The only time that may not come into play is when you have multiple historians that are giving you a conflict and you can't figure out what information is true and not. But that still satisfies the fact that you were using an independent historian. And your typical patients are going to be your infants, your young children, your autistic, your psychiatric or neurologic impaired patients, the ones that with dementia or delusions. So this is an example. Dr. D calls the teacher of a patient who's being treated for ADHD and a learning disability. The medicines were recently changed. Teacher reports students' work is improved, making progress. That is an independent historian. These are the charts from the AMA that kind of go through this. Remember, we only need one of these 2 categories to be met. So in column 1 here, we've actually met both of them. So if you'll see, the green, we meet. All we need is to meet one of the 2, and we do it. If we don't meet any, then it doesn't count. So moderate data, we now move the independent historian up into category 1, but now we need 3, not 2. But we only need to meet one of these 3 categories. They've added this independent interpretation of tests, and I'll show you what that means. And then discussion, of course, if you discuss with somebody outside of your office, another specialist, another physician, or these external sources. So this independent interpretation, I'm not going to spend a whole lot of time. It's mainly for specialists and things, but it's basically, if you have a test that was a tracing, an image or specimen that's done outside of your office, you're not billing for it, but you have to interpret it for something specific for that patient visit, then you can include that as part of your data. Some examples of that are like an EKG. You know, you do an EKG in office, patient has a new right bundle or has a right bundle branch, old flip T-wave. If you don't have an old EKG, the patient gives you an EKG that's on his phone that doesn't have an interpretation. Again, it does not have an interpretation. Then you see the old right bundle branch block, old inferior T waves, you document that, that counts. If somehow you can do a wet read of an x-ray before the radiologist reads it, some places can do that, you can pull it up online, that would count too. But if you pull up an x-ray report and a radiology report, that doesn't count. If you do an EKG that's a computer interpretation, that doesn't count. So remember, for our moderate level, we've got to satisfy one of the 3 categories. So anything here from 1 and above satisfies it. The independent historian, discussion outside of our office, or any 3 of these activities or any combination, 3 unique tests, 3 notes, 1 test, 1 note, 1 review, whatever makes up that 3 activities. And then of course for high, we are using the exact same thing as the moderate, but now you have to satisfy 2 of the 3 categories. So again, 1 won't do it. If you only satisfy 1 of these categories, you've got to satisfy 2 of them. Just to show you these all side by side, again, the low, we're meeting 1 of the 2 categories. We only have 2 categories. You only need 2 from category 1. As we move to moderate, now we have 3 categories, and we've moved the independent historian up there, but we only have to meet 1 of the 3. And then for high, we've got to meet 2 of the 3. So this shows you an example. You know, I did kind of a bilateral or kind of a mixed one here. We got a 3-year-old in a pediatrician's office, an 85-year-old with dementia, came from the urgent care. The provider reads the note from the urgent care, reviewed the CBC test that's done at the urgent care, and then obtains the history from the dad or the daughter. So this is moderate data. You reviewed a note, you reviewed a test, and you had an independent historian. You met one of the three categories. The last one is risk. And risk are complications, morbidity, and mortality that are due to patient management decisions. This one includes, and it's very important to understand this, ones you choose and ones that you didn't choose but you considered. To make sure everybody understands the definition that the AMA is using for morbidity, it's a state of illness, functional impairment that is expected to be substantial duration, during which function is limited, quality of life is impaired, or organ damage that may not be transient despite treatment. If you consider it, it equals action taken. It's part of your MDM. So a couple decisions here. You have to make a decision about hospitalization. Patient's kind of borderline. You're not sure if you want to go. And then you find that the patient has really good care at home. He has people 24/7. You decide not to admit, we're going to try this as an outpatient. That still counts as decision for hospitalization. Psychiatric patient that may need to go inpatient, but you decide because of their outpatient support, they can go home first. So that, again, is a decision for hospitalization. And then the decision not to hospitalize the patient with advanced dementia because you basically only want to do palliative care. Again, the patient meets the criteria to probably go in the hospital, but because of your decision to de-escalate care, you're going to send them home. Straightforward, there's no real risk. This is something like tinea or benign nevus. Your 203s, you're low. There's a low risk. So this would be your allergic rhinitis, URI, pharyngitis. Now, where we get into some of the difficulty here in interpretation is when we start getting into the moderates, the 204, 214. Prescription drug management. You write a drug, you refill a drug, you start a drug, you're going to be automatically, you're going to check the box in element 3 of risk for moderate. If you have to make some decisions on minor surgery because there's potential complications, like they're on blood thinners and they've got to get a hemorrhoid or a biopsy or an abscess, that would qualify. Or if they come to you and you've got to make a decision to send them for major surgery like carotid surgery or bypass surgery, that also qualifies. And then if your diagnosis is limited by their social determinants of health, this automatically qualifies you for risk, again, whether you write a prescription or not. I've tried to make a list of every one of those that I think would play into this, homelessness, poverty, difficult child welfare. There's a lot of different, but it's going to be one of the Z codes here that you could use. And if you use that Z code, that's going to help you justify that moderate level of risk. Of course, the high level of risk, this is the one that throws a little people off a little bit. This drug therapy requiring intensive monitoring, which I'll go through some examples. An elective procedure, major surgery, where they do have risks. Okay, say like they're going to EGD or colon, they've got to be on blood thinners, or their surgery in a poorly controlled diabetic. Then, of course, a decision for major surgery is going to be a kind of a no-brainer. They need coronary artery bypass. They've got an LED that's not suitable for PCI. They got a leaking aneurysm, perforated ulcer, bowel obstruction. Something's going to need immediate. But the hospitalization is the one you're going to use the most. And again, you don't have to admit. You just have to consider. And DNR, same thing. You don't have to technically make them a DR, but you have to talk about de-escalating care. So this drug requiring intensive monitoring, it's one that's you're monitoring. It's a therapeutic agent, but it has a potential to cause serious morbidity or death. Your monitoring is performed for adverse events, not for therapeutic efficacy. And I'll show you an example of this. The monitoring should be a generally accepted practice, but the patient, it may be patient specific. So an example would be short-term intensive monitoring of electrolytes and renal function in a patient that you're going to aggressively diurese for CHF. This is per the AMA, so this example came straight from them. Some other things like digoxin and amiodarone, we have to start, initiate, and you have to check an EKG at 2 to 4 weeks for the QT interval, or an inpatient treatment with certain drugs like, initiating treatment with certain drugs like Dilantin and flecainide as an outpatient, where you're going to initially could have some bad toxicity until you see how the patient's levels are going to come out. The intensive monitoring can be long or short-term. Long-term, it has to be performed not less than quarterly. The monitoring has to be performed at the laboratory, physiologic, or imaging study. It can't be monitored by history or exam. That doesn't qualify, and this will affect your level of MDM. What doesn't count is, an example here is monitoring of glucose level during insulin therapy. It doesn't qualify because the primary reason you're monitoring is therapeutic effect, even if it is hypoglycemia is a concern. So annual electrolytes and renal function in a patient on diuretic. Well, that's not less than quarterly or less, so that doesn't fit. Now, if you start doing it quarterly, that doesn't qualify because that's not the expected normal practice. Here's some things for pediatricians as far as risk. You'll see the moderate and high are pretty much straightforward, but for minimal, the drink plenty of fluids, diaper ointment, superficial wound healing, over-the-counter, remove stitches, physical language, or occupational therapy. So, again, I want to emphasize this coding alert. The final diagnosis that you make does not in itself determine the complexity. If you had to undergo an extensive evaluation to reach that conclusion, then this could, and he'd come up with something that's fairly benign, even though there was some highly morbid conditions considered, that's going to still give you a higher level of MDM as long as you document that. Multiple problems of lower severity may create a higher risk due to interaction. So we got somebody with fever, body ache, sore throat, nausea, vomiting, diarrhea, all of which are pretty self-limited by themselves usually. So, but our differential could be COVID versus flu versus upper respiratory versus gastroenteritis. So we're talking about something that could be self-limited versus acute with systemic. And in the COVID, it could actually be even worse. It could be a high. So again, the aggregate of these determines how you document what you went through in your decision making. So here's a very simple one. Patient presents with follow-up for treatment of otitis. You tell them the effusion is going to get better. You don't say there's any treatment that you need to do. That's going to be straightforward. You've got one self-limited minor problem that's going to get better on its own. There's no data, and you're not prescribing anything. Now, you've got a newer established patient who presents with right ear pain. You use the diagnosis of acute otitis media without rupture. Well, again, now this is a low MDM supported by an uncomplicated illness. There's still no data, and you've written a drug. So now you've got one in category low, one in category straightforward, one in category moderate. Prescription drug management does support moderate risk. So anytime you do that, you're already moderate, but not a moderate MDM. Remember, you need 2 of the 3 elements. So this is going to be a low MDM because the moderate risk for the drug management is going to go backwards to the low. So you're going to have 2 in the low. You have, like I say, if you have 1 in each one of those categories, the highest one's going to go back to the next lowest one. Now you've got the same patient with cough, sore throat for 3 days with postnasal drainage and sinus and no sinus pressure. So the provider orders a strep test. It's negative, indicates the diagnosis URI. Now just prescribes over-the-counter medicines. Well, as opposed to our straightforward, the last time, this is actually low because now we've got an acute uncomplicated illness. There's low risk of morbidity, and we did tell them to use over-the-counter medicine. So this would qualify as a 203 versus or a 213. Now, a typical patient here that comes in with a laundry list, they come in for the refill of their ADHD medicines, which are stable. They've got a rash in their groin, which is pretty much self-limited, but they've tried over-the-counter, it hasn't worked. They've got water eyes, stuffy nose with seasonal allergies, knee pain, mole on the right arm. Well, you take all the medical relevant history. Its time takes you less than 30 minutes. And let's look at the problem. So you refill the ADH meds. Well, now you've done a stable chronic illness, okay? That's a low level of MDM. You've got a rash that hasn't gotten better, so that's acute uncomplicated. Again, that is low. You've got the watery eyes, the postnasal drift. You use Zyrtec over the counter. Again, another acute uncomplicated. You got a knee pain. You give them a prescription for a Toladoc. You still got another acute uncomplicated, and then you look at their mole on their arm and say it's acute nevus. You don't have to do anything. Again, another acute uncomplicated or self-limited. So you got like 5 or 6 different acute uncomplicateds. Well, unfortunately, the way this works, in the past, you start counting those things and document, you get a higher level. But under the new medical decision making, you've got multiple uncomplicated illnesses. You've got one stable illness. You've got no data, and you're prescribing. So you've got one again in each column. This one defaults back to the low. So even though you've got multiple problems there, unfortunately, you can only code this as a low. Now, documenting complexity, that's a whole different thing. Fever, 100.3 in a 4-year-old. Fever got better with Tylenol, been acting sick at daycare, is confused, vomited. So there's multiple things going on here. Fever, confusion, vomiting. That could be of at least moderate risk, but the provider only documents otitis media. I said the symptoms related to otitis, so he prescribes antibiotics. Well, if the provider was concerned about the complexity, then he has to notify that the confusion, the other things, he considered other diagnoses other than otitis. And if he did that, then he would have a more complex documentation. So if you think it, you've got to document it. So again, we had a low visit. We had an acute uncomplicated illness. We prescribed a drug, none. This is going to default to low. So we've got 2 in the low. And this was a low complex MDM. Now, if he would have stated that those other symptoms, he was concerned about meningitis or some other symptom, now you've got an acute illness with systemic symptoms, and now you've got 2 in the moderate, so now it becomes a moderate. Your established patient with worsening or asthma at home, not relieved by home inhalation treatment, comes into your office. They've been using their albuterol nebulizer. They're not using any other inhaled inhalers. You do a spirometry. and you give them a sample of a new inhaled steroid. You don't prescribe it, you just give them a sample. You use the diagnosis of mild persistent asthma. Well, in this case, you're going to get moderate. Now, you gave them a sample, you didn't prescribe. Why is that a prescription drug? Well, I'll show you that in a second. You had one illness with a mild exacerbation. You've got no data. The spirometry, remember, you're billing for outside of the with a CPT code, so it doesn't count, but it didn't matter because you've got 2 of 3 anyway. So this would be a moderate level, 204, 214. So a prescription drug counts whether you give them a piece of paper or you give them a sample, because the risk and the thought process remains the same. So that counts as a prescription drug. So remember, again, these examples are not a substitute for your judgment. Each individual patient, you've got to make your own clinical decisions. So let's take this patient with migraines. They tried OTCs, they've diet, nothing's helping. They've had migraines for many years. They've been worsening intensity and frequency. They've been using their Maxalt about 10 times a month, taking Tylenol and Advil. You diagnose migraine, you prescribe Maxalt, and you add Topamax. So what do we have here? Well, we've got migraines that are getting progressively worse, so that's a moderate. We gave them prescription drugs, so this qualifies as 99204-214. That same patient comes back on the Topamax, better control, the frequency's better, patient's happy with results, you refill the medicines, follow up in 6 months, but then they also say they're having problems with postnasal drip and itchy eyes. Over the counter isn't helping, so you give Mastone nasal spray. Well, now you've got one stable illness, your migraines got better, so now you're back to a low complexity. You got an uncomplicated acute injury, which is allergic rhinitis. Again, you don't get credit for both. You're still on the low. You have no data, and your prescription now will go back to the low. So again, this patient, even though they're following up, they're stable, they had another complaint, they're still a low 99203 or 213. Now the migraine patient, again, using the Topamax and infrequently with the Maxalt, the same thing. You refill the Maxalt and Topamax, they're doing together, follow up in 6 months. They still have the itchy eyes, you give Maslin, but also they need to refill their trazodone for insomnia. So you take that same patient, now you have 2 or more chronic illnesses, this insomnia and the migraines. So now you've moved to a moderate level. You still have that allergic rhinitis, but that doesn't count. You always take the highest one. So now you've got 2 of 3 in the moderate. Now, patient that's in your office, come in with headaches and visual disturbance, has a seizure. The seizure lasts 5 minutes. Patient's confused, short of breath. They probably aspirated. EMS is called. The patient is transferred to ED. Everything's done in less than 30 minutes. That patient's in and out. Well, if you're doing this by time, you're going to be, and we're going to show you that in a little bit, this would be a moderate type 99214. However, because this is a severe illness with a threat to body and injury, this is a high level of number and complexity. You had to make a decision regarding hospitalization. You had no data. So even though you spent less than 30 minutes, this is either a 99205 or 215. Now let me show you how disease can be all different diagnoses. Asthma care plan, where the nurse is just reviewing it, that's going to be a 99211. You have the controlled asthma, but the patient wants to ask you about using the inhaler before exercise. Well, that's a 99212. That's a pretty low MDM. And then a stable asthma where you're just refilling their medicine, that of course is going to be the 99213. And if it's getting mildly worse, you have to change the medicines. That is going to qualify as a 4, because now your problem becomes a moderate problem because you have an exacerbation. And of course, if they're having difficulty and they're in your office, they're not getting better, you give them steroids, nebulizers, you call EMS because you got to get them in the hospital. Now you've got a threat to body, life, and function, and you've got a need for hospitalization, so that becomes a high. But a patient that just comes in for a follow-up with their ADH and asthma, they're both doing fine. They refill the asthma medicines, you refill the Adderall, schedule a follow-up in 3 months. Well, again, you've got 2 or more stable conditions, moderate, 994, 204, 214, and prescription drug management, because you've got 2 of the 3 elements. So some questions: do parents count as independent historians at any age? Well, AMA says parent does count as an independent historian, and there's no age limit. It's just the clinician must not be able to get the history from the patient. That's the big thing, and it must be a reliable history and something that's necessary to the complaint. Now, what I talked about here, the strep mono, these tests here, remember, the AMA says if you perform a test and you bill a CPT code in addition to E&M, which you're going to bill, it shouldn't count. Well, it really, to me, doesn't matter, because all of those illnesses that you're checking those rapid tests for, the mono, all those things, strep, flu, they're all considered acute uncomplicated. So no matter what you do here, you're going to be in the acute uncomplicated. Very rarely would you ever order 3 of them at once, but I guess there's a possibility you could, but that would be the exception. even if you give them a drug or don't give them a drug, you're still going to end up with a low. So the data really doesn't matter. In my opinion, I really think these should be counted because they're not those things that they're talking about with the CPT codes are things that they're talking about that have more or less where you have to do analysis and you have to do reporting and things like this. This is basically positive or negative. So to me, these things should count. And I think the AMA is going to clarify this because it's a big debate right now based on their literal definition. Another question, if I do a CT scan on July 1st, I review it with the patient on the 8th, does the order count? And then the review on the 8th? No, remember, you order it on the 1st, that's when your order and review count. When you're away on vacation, your patient, one of your partners orders labs and reviews the labs, you come back, do you get credit for the review? No. If they're in the same specialty, you don't get credit. The person that ordered them and reviewed them gets credit. So the next thing that's been changed is time. Remember, I said you can choose this on MDM or time. I think 80% of the time you're going to choose MDM, but occasionally you're going to end up with time. And this is for all the codes. It's not the time that you spend in face-to-face, which is what which has been for forever here now since '95. It's the total time of the day. So even though that's changed, it's the total time spent on the day. What hasn't changed is the medical necessity for the level of service and the time spent. So you have to justify the time that you spend. Again, with MDM, there is no time. You can spend 2 minutes or 20 minutes. So it doesn't matter. It's the level that you get on that 3 elements. And I said most claims will be based on that. If your MDM is low and your time is moderate, you're going to use moderate. But remember, time is only on the date of the encounter. Labs reviewed prior to the encounter are not included. So CPT says 3 days before and 7 days later is pretty much what an encounter is. So these are the times that we have right now, 20, 30, 45, 60. They've been changed to what you ought to remember is 15, 30, 45, and 60. And the one you're going to remember the most is the 10, 20, 30, 40. They made it pretty simple for the follow-up patients. 10, 20, 30, 40 established to the 212 through the 215. So this is what we're going to look at. Again, this is where we are today. This is where we are starting January 1. So remember, right now, you can only use time if 50% of the visit is for counseling and coordinating care, and it's only face-to-face. In 2021, that no longer applies. You can count total time in the date of encounter no matter what you're doing as long as it involves the counseling or care coordination. So remember, it has to be on the same day. So these are the things that are included. Preparing for the patient visit, such as reviewing test results, obtaining or reviewing history, performing a medically necessary exam, educating or counseling the patient and the family, ordering tests, medications, procedures, referrals to a specialist, or communicating with other providers or an external source, and we'll define that external source here in a second. Documenting clinical information in the EHR. Now, if you're a very slow typer, again, remember, your time has to be justified. If it takes you 30 minutes to type in a paragraph, that's not going to fly in an audit. If you have to do an extensive note, again, remember, you don't have to include a lot of information. So when you're doing that for some other reason. And so theoretically, that may not be medically necessary. So you got to watch how you include your time. And then care coordination, that you're not reporting otherwise. And then again, if you're independently reporting any of these results. So who are these external sources? Well, that'd be a specialist. You got to call another primary care that's outside your office that may have taken care of the patient before, or somebody that's seen a lawyer, a police officer, again, teacher, ADHD, or a case manager. Now, if you're billing for case management in your office, you can't do that. But if you're outside, if you're not, then you can talk to a case manager. So here's a couple examples. Again, we talked about the PEDS talking to the teacher. Can include a discussion with law enforcement. Again, if you have to call the patient's previous primary care specialist. Things that aren't included is clinical staff getting a pre-auth. That doesn't count. But if you got to get on the phone and talk to your patient or talk to the peer-to-peer, that is related to your MDM. Time used by your nurse to take a history is not included. Time used by the staff to perform in-house testing like rapid tests, EKGs, those things are not counted. And time that you spend on a procedure that you're going to bill, usually using a 0.25 modifier, that's not included. So let's look at an example here. Patient comes in for the URI. Your nurse spends 5 minutes getting all the information in. You spend 10 minutes examining the patient, getting additional history. You order a strep test. It takes your staff 20 minutes. You go back in after you get the results of the strep and tell them they're positive, prescribe a medicine. You finish charting. That takes a total of 8 minutes. Your total time is that 10 minutes plus that 8 minutes. Straightforward, 99212. However, this is one where you got to look at your MDM. Your number of problems is low, okay? It's an uncomplicated illness. Your data, if you count the strep or don't count the strep, we'll say none, but it's still going to be, you're still not going to meet the criteria for the 2 in the low. But your decision making is you prescribed an antibiotic. So now you want to choose MDM over time because your MDM equals low, your time equals straightforward. So again, you can look at both of these. You can't double dip though. If your mid-level sees the patient together with them, you can't count both times. You can't include the time that you have to discuss the patient with the mid-level outside of the patient room. So I'll give you an example of that. The patient comes in, they're concerned about the resolution of their otitis. 5 minutes are spent reviewing the chart by the mid-level, and then it's noted the child is unimmunized. So after a brief examination, and talking to them about immunizations and the importance for that, the nurse practitioner or PA spends 10 minutes. Then the PA nurse practitioner goes out and talks to the pediatrician for 5 minutes, updating them on the issues. The pediatrician and the nurse practitioner go back in, they answer questions, they try and counsel the patient again, try and talk them into the immunizations. They spend 10 minutes. Parents again refuse. So the nurse practitioner finishes up the note, takes 5 minutes documenting the time. What time counts? Well, the 5 minutes that they started the review, the 10 minutes for the examination, and the 10 minutes, not the 20, not for both. They only get to count 10 minutes there, even though both of them were in there. And then the 5 minutes for the follow-up or to finish up. That's a total of 30 minutes, not 40 minutes. So you can only report a minute for one person, even if there's 2 or 3 of you in there. Modifier 25, this is going to be any procedure you do. You cannot count this in your time either. You are billing for this. You're getting paid for that service. So here's an example. Patient comes in for elbow pain, failed nonsteroidal, home exercise and rest. You spend 5 minutes updating the history and exam, decide to do a joint injection. Takes about 10 minutes. You spend another 5 minutes documenting in the chart. Your total time is going to be 5 minutes for updating that history and 5 minutes for documenting. That's 10 minutes, or that's straightforward. So if you're going to bill it that way under time, you're going to use a 99212 with a 0.25 modifier and a CPT for injecting the elbow. Whereas your MDM, you're dealing with an acute uncomplicated injury. So your risk is low. Your data is none. I mean, your number of problems is low. Your data is none, and your risk is low. So that actually is a 99213. So again, you're going to choose MDM over time, use your modifier 0.25, and bill it with the injection for the elbow. Telemed is a completely different animal. Each payer is going to have their own thing, and I'm going to defer you to talk to your payers about how they're going to handle E&M codes in telemed. Another example of time. You've got a patient that comes in with a lower back mass that's getting larger. You spend 5 minutes reviewing the chart. Well, the patient has a BMI of 45. He's hard getting around. After you take the history, it takes you a while to get him in position to examine, and then you have to try and get him back down off the table into the chair. He's also from overseas, has limited English, so you're getting all this from his daughter, who's translating. The result is you spent 23 minutes face-to-face. Again, you document exact minutes. When they do a review, they don't want to see 20 minutes, 25, 30. They want to see exact minutes, so you use 23. So the doctor said, hey, this is a lump, it's a lipoma, doesn't require treatment. He takes 5 more minutes to complete his note. So his time is 33 minutes. The 5 minutes he reviewed, the 23 minutes he spent with the patient, and the 5 minutes that he spent finishing up the chart. In an MDM, again, this is where you're going to choose time over MDM. In MDM, you've got a presenting problem with minor requires no treatment. That's either straightforward or low. However, remember 10, 20, 30, 40. Your time's over 30 here and less than 40, so your time is actually a 99214. So even though the presenting problem was not minor, you're going to use time as your example. And again, this just shows you the difference. Remember, it has to be on the same day. So all of this was done on the same day. They reviewed, they saw the patient, they talked to the subspecialist, and then the caregiver. So they did a total of 50. But if they reviewed the labs the day before and talked to the subspecialist the day after, they only did 30. So it drops the level down from a 204 to 203 or a 215 to a 214. So remember, it's only time on the day of the encounter. So if you're using time to select an EM code, should you use a time range or actual time? You want to document actual time and the activities you perform. Do you want to list all the activities and time spent during each one? Yes. The AMA says you have to list the total time and describe what activities were done. I spent 42 minutes caring for this patient today, reviewing labs from another facility, seeing the patient, documenting the record, arranging for the sleep study. So a patient, a 65-year-old, comes in for a check. For his labs that were drawn yesterday, the hemoglobin A1C is 9. The last one was 7.5. The BNP is normal, 162 over 102. And his last blood pressure was stable. The last time you saw him, and his LDL was stable last time at 80. Now it's 165, as well as his TSH. You say, what's going on here? Well, the patient lost his job and his insurance. He's not taking his meds. He's got no symptoms from the above. He's been stable for over 2 years when he was on his meds. So do you consider this an exacerbation of a chronic illness or non-compliance? That's up to you. But he now has his job, his insurance is back. So you restart his meds, tell him to check his sugars, blood pressure, call if it goes above the target. The total time you spent is 20 minutes. Well, 10, 20, 30, 40, that's a low MDM. However, if we use medical decision making, we've got at least, these aren't stable. Again, these are illnesses with mild exacerbation, or they're unstable. So you can't really use the 2 or more stable. But they were stable when they were on the medicine. So again, this is judgment call, but it doesn't matter. You're still going to be in the moderate. You reviewed all those tests, so you're going to be in the moderate there, and you prescribe medicines. So you want to use MDM over time here, and you want to use a moderate. So patient presents for follow-up of depression. They've been doing fine. You check their look at their last 3 encounters with their psychologist. You see the labs that they've been doing are normal, the ones that came in for this visit. The meds have been working. But the patient has some other concerns about psychosocial issues interfering with their personal relationships. So you spend 25 minutes talking to this patient, even though she says her depression, other things seem to be stable, and you refill her prescriptions. You tell her she needs to reconnect with her psychologist, spend another 10 minutes completing the referral, sending electronic prescription, then documenting the counter. You spent a total of 15 minutes here. So you use major depressive disorder. This qualifies, again, 10, 20, 30, 40, 50, or 10, 20, 30, 40. 40 minutes to 55 minutes is actually a 99215. So this would be a 99215. However, if we used MDM, we'd have 1 or more chronic illnesses with a mild exacerbation. We did review the test. We did prescribe. This would only be a moderate. But again, the time, because it's 40 to 54 minutes, would be a high level or a 99215. An established female patient presents to the office with her daughter. She's been stable for depression, but she's having frustration, losing objects. The daughter confirms this, as the patient frequently forgets names, isn't able to remember words. Her depressive symptoms, though, have been stable on her medicines. So you review the labs that were drawn, you order an MRI, you renew her antidepressive medicine. The total time is 28 minutes. You order a neuropsych testing. So again, 28 minutes equals a 99213. But your medical decision making is a moderate, because you've got 1 undiagnosed new problem, which is this memory issue. You've got 1 stable. Again, you take the highest one. You reviewed all of these tests, so you've satisfied category 1. And remember, in moderate, you only have to do 1 of the 3, and you prescribe. So this is a moderate level. You're going to use MDM over time. So let's talk a little bit about what you have to document. This is a new patient that comes to you, coronary disease, stent. They want to establish care. They bring a copy of their last labs and their cardiology note for you to review. They've been taking their diuretics, monitoring their weight. They've been instructed, they have not been taking their diuretics and weight as they've been instructed, since they moved here 6 months ago. So they've only been trying to stretch their medicines out. This happens quite frequently, I think. And the exam, you see some pedal edema. They have a little bit of a higher respiratory rate, crackles, but their O2 sats are good. They look fairly stable. But since you've never seen the patient, you call the previous cardiologist who said, yes, this patient is well controlled, been taking, when he's taking his meds, he recommends increasing the diuretics, monitoring the BNP, and getting an echo. So you order the echo. You want to order a baseline today to see what his labs are. So you order those 3 labs. You prescribe the Lasix at a higher dose for 3 days, and then back to his other dose. And then you order a BNP in a week, because again, you're doing a fairly aggressive diuresis in outpatient. You want to make sure he doesn't have problems with his potassium or creatinine. The encounter takes 40 minutes. So again, by time, 45 to 59 minutes is a 203. If this is a new patient, if it's an established patient, again, 10, 20, 30, 40, it would be different. But this is a new patient, so 30 to 44 minutes would be a 99203. But if we're doing an MDM, let's look at what we have here. We've documented all these different things. We've ordered these labs, which was a total of 6. We've talked to an outside source. So we've done 2 of the 3 here. So we've checked the box in the second column, and the drug therapy requiring intensive monitoring for toxicity. So we've now got 2 of the 3 in high. So this actually becomes a 99205 or 215. And when you're documenting it, again, you've documented that you've got shortness of breath with CHF. So you've documented your problem. You've given a little bit of the history, but to make the note kind of flush with what your decision making is. These are a little off here, but your case was discussed with cardiology. Well, that's data in category 3. You reviewed the BMP, the LFT, the CMP, and the notes. That's data from category 1. And remember, you have to satisfy 2 data components. So you've satisfied data 1 and data 3. And then you've checked this BMP for renal function and potassium. That is the drug toxicity monitoring. So now you've checked the box for risk. And again, here's some other data. So you've satisfied your note to show that you have done medical decision-making at a level of 99205. A return patient for hypertension, well-controlled, no new complaints, taking meds, no side effects. Basic, someone comes in just for a med check, you listen to heart and lungs, you refill the meds. Kind of takes about 15 minutes. By time, again, 99213, 10, 20, 30, 40. I'm sorry, by time, that's actually 10, 20, 30, 40. It's actually a straightforward. I'm sorry, that's wrong on this. It should be a 99212. And then the MDM, though, that would be moderate, okay? Why would it be moderate? Well, you've got 2 or more stable illnesses that you're treating, you've reviewed the tests, and you're doing prescription drug management. So, again, this is where you would use the MDM over the time. And when you're documenting it, again, you've documented the 2 or more stable problems, that you reviewed the medicines, that you've reviewed the labs, and you've provided the refills, which is the prescription. So you've got your 3 components that document your moderate level of complexity. So documentation, even though they changed and you don't have to include as much, you want to remember that your note's going to be used by outside people, specialists, life or accident insurance, CMS, commercial payers, legal, continuity of care, RAF, risk adjustment, others. So you want to make sure that that you document all those things appropriately so other people can use your note. The thing that has changed is this prolonged time code. There's a new code for 2021. It's total time on the date of the encounter. It includes both face-to-face and non-face-to-face. It does not include times and activity that are normally performed by the clinical staff. It is full 15-minute increments, and it's only used when you exceed the time for a 205 or a 215. So 205 goes up to 74 minutes. So if you go 15 minutes over those 74 minutes, then you would report 199417 code for every full 15 minutes. If you go over 215, which is 55 minutes, or 54 minutes, 55 minutes, you would report the code for every 15 minutes you go over that 55 minutes. So an example at 99215 has a total of 93 minutes. You exceed the 55 minutes by 38. So you basically have a 99215, and you have 2 levels of the 99417 because the 38 minutes divided by 15 is 2. Again, you don't count those extra 8 minutes. So if you go over by 20 minutes, only a 99417 would count. And if you go over the typical time by 32 minutes, again, 99417 times 2. And this just goes to show you that in this chart. Case management, you can never bill on the same days that you're billing this 99205 or 215 under the new rules. The old 993, or not, shouldn't say old, the one we've used with the contact face-to-face for anything that's over 30 minutes past our 99215s, we no longer can bill on the same day as a 99215, especially if we're using a 99417. The same thing with the 99358, which is the prolonged over 30 minutes up to 60 minutes for the non-face-to-face. You can't bill it on the same day. But there is a place you can bill it, and that's when you use a 99358 on a day separate from the encounter but related to the E&M of the previous visit. So a patient you saw a week and a half ago or a week ago comes, a pile of records come in, it takes you 30 to 40 minutes to review those records. Well, that's not typical. So the AMA has said, hey, you can, even though you billed a prolonged services already on this patient, you can bill this code because this is not typical if you spend over 30 minutes, and you would bill this code for up to 30 minutes, for over 30 minutes up to 60 minutes. The new code for the that's going to be, I think, something that is going to be very beneficial to primary care is this G221. 11. It is a new code. It was just introduced again last night. They finally gave it a number. It's an add-on code reporting in addition new established office visit. It's primary care medical complexity. It's used for all levels of care for new and established office visits. It can be used by specialists, but again, I think it's mainly designed for primary care because it describes the work that we do for the visits that are ongoing, comprehensive to a patient's single, serious, or complex condition. So there's stuff that we do on an ongoing basis we've never been compensated for. Well, they haven't released the value, but if you use the RVUs and try and come up with something, right now it looks like it's between 10 and 15. It could be less, it could be more, but that's a pretty good guess. Last night they said in the proposed rule, we, Medicare, assumed this code would be reported with 100% of office E&M codes by specialties that rely on office outpatient EM visits to report the majority of their services. So CMS is assuming that primary care will use this code almost 100% of the time, starting on January 1. And why? Well, they continue to believe that even with the updated RVU values, E&M services, these codes don't accurately reflect the resources required to care for patients in primary care and certain non-procedural specialties. It's inherently distinct from those codes we use right now for preventative and care management services. The primary care use this code for furnishing services to patient on an ongoing basis that result in comprehensive, longitudinal, continued relationship with the patient. It involves a team-based care that is accessible, coordinated, and integrated. So it's basically giving us credit for all the things we've done for years but never been paid for. A brief comment here on relative value units. Of course, this is how our compensation is divided in Medicare. The current value for every RVU of work we do, RVU is 36.0896. The RVU is based on 3 different components: the work we do, our practice, expense, and malpractice. So these changes are going to improve RVUs for new and established office visits. There's going to be kind of an unequal increase. Like I say, last night they announced that this was going to take effect. However, they're going to decrease the conversion factor from 36 to 32.26. The practice expense is going to decrease. So what that means is those providers that do a lot of specialty type procedures or do things outside of E&M are all going to take a decrease, so that the physicians that do mainly the E&M codes like primary care are going to get a raise. So basically, I think for the first time, primary care has finally got the recognition we deserve. Now, again, these are estimates. They have not released these numbers, but if you look at the RVUs, you try and use the current ones, this is kind of what you're going to see, is that a lot of our new patient visits are actually going to go down a bit. But the big thing is going to be the established visits, where you're going to see about a 17% increase, 14, 11 for 16. So you're going to see 110 to 133, 123 on the 214, 76 to 86. And then you've got that G2211 that you're going to be able to add on to this, which could be another anywhere from $10 to $15. Of course, the big thing was before COVID hit that they were going to change this, that no matter what you build, a 203, 204, 202, you're going to get 130. And if you build a 212, 213, 214, you're going to get a flat 90. Well, with COVID, they realized this was going to kill a lot of specialty, a lot of people from a financial standpoint, and that's why they're leaving those increases in check. And I did the typical thing for one clinic here on just what they build, and if they build the same this year under that flat rate, because they built so many 214s, they would actually lost $5,800. So in summary, what we have is we've got January 1, we've got these new codes that are taking place for the 99202 through the 99215. We've got the codes that have been added and deleted. We've got the 99201, which is eliminated, the 99417, which has been added for 15 minutes for the prolonged visit, and the G2211, it's added for every E&M for primary care. And then we've got the history and exam changes. The history and exam will not impact the level of care, but you need to medically appropriate the documentation. Or, I mean, you need to document medically appropriate things that are part of the history and exam. And then, of course, the MDM or time, you get to choose between which one you want. Do you want to do the level of care driven by medical decision-making or time? So again, there's a lot of different moving parts here. There's a lot of changes. I think the big thing is to get that for the MDM, to get that chart with the 3 elements, keep that close to you, kind of memorize that. That's going to drive a lot of your coding and a lot of your decisions. If you're going to record time, record exact time. I hope this was somewhat helpful for everyone. Again, I know it's somewhat confusing, but hopefully you got some good information out of it. Take care and have a good night.